Hey, good afternoon. My name is David Hebert. I'm the ECMO coordinator at Children's of New Orleans. I'm a respiratory therapist. I've been a therapist for about 22 years. I was really skinny and had hair when I started. Now I've learned through Eric's talk that high BMIs are not good, but it makes you harder to kidnap, so I feel better. So I'm really appreciative to be here. When I asked to speak at the symposium, there's a list of 4 or 5 options, and I didn't respond immediately. And then so all of a sudden, John sent me an email, so you can talk about cannulas, excuse me. I'm set to perfusions. That's really scary. So I kind of took a different approach to it, and I think, show of hands, how many people here do not work in the ECMO center? Everyone? Okay, good. So good. Oh, nice to know. So we're going to talk about cannula patient and circuit management, and kind of coming from a neo-ped standpoint, I'm going to talk mostly about what we kind of do, and I have a little bit adult information, not much, but I just want to more like a roundtable discussion. So if you have a question, raise your hand. It's okay to interrupt me. I won't be offended. Just kind of go through some of the things that I've learned over the last 20-something years by practicing ECMO only one way, which sounds kind of scary, I think, but I think it's made me better in our center to better hone in on what works best for our kids. So I have nothing to disclose or disclaim. So what are we going to talk about? Again, about what I just said. So anybody here really ECMO nerd? I really love what I do. I have a huge passion for it. So anything I find ECMO online, I put in my office, and people laugh at me, and they think when I walk through units, they think I'm going around just to cannulate people. And it's just because I'm just checking, I guess, but I'm not weaning any dopamine or anything. So I met Dr. Bartlett about 3 years ago in Austin, and he spoke like 4 lectures before me, and I was just in awe that he was there. And so I waited for him like a little fangirl to get off the stage. And I kind of chased him down like the Beatles were here, right? And I was, oh my God, so we took a picture together. It sits in my office, and people say, is that your dad? I'm like, no, it's not my dad, but it was really cool to meet him. And I told him how much I loved him. He's like, yeah, that's great, get away. But no, he was really nice about it. Okay, so the cannulation techniques and management. So there's so many options for cannulas, right? Cannulas, excuse me, yes. And these are just some of the listings I saw, on the ELSO website. We mostly use Medtronic because it works for our patient population. But again, you guys see the different options here. Again, just so many options. So when you look at cannulas, they have different characteristics, right? So some of you have arterial, you have DLPs, you have Biomedicus, OptiSight from Edwards, and you have different types of venous cannulas, obviously. Single stage, double stage, triple stage. And then finally, something new came out from a vendor, I'm not going to say our name. They have dual cannulas that could offer either for drainage or return flow, something kind of new, so that's interesting to look at in the future. And there's some of the other ideas. You look at your flow ratings, of course, your depth markings, radio-opaque aspects, if there comes an introducer or not, you want to know that beforehand, right? Do you have enough side holes, your population suture collars, size selection, and the biggest thing is talk about coding, not just for cannulas, but for circuits also. So it seems to be a huge topic in the ECMO world about what coding is better for a circuit, how long does the coding really last? I've not seen one independent study to say which coding is best. It always comes from that vendor. So it's just a lot of things to consider for your program. So cannulation techniques, and so most of our patients are cut down, but there are some percutaneous. So some of the pros of it are, they're pretty successful. Suggested to be used with ultrasound guidance, and can be performed by trained intensivists. So who here knows any surgeon in the world that would trust an intensivist to put a cannula in for him? None, right? Not that I know, at least. But it's something that's kind of grown in the past. They talk about intensivists doing this. I don't think it's been really well received by many surgeons. And of course, lower infection rates. Some of the cons are you need ultrasound guidance for it, possible hematomas and infiltrations for that. So that's some of the issues. Modified CUTDOWN, what we do mostly. Most of our kids, we do about 20 cases a year in our center. Most are 10 kilos or less. So we cannulate mostly in the neck unless it's coming out of cardiac surgery. So I've seen a couple, in my 20-some years, I've seen 5 patients where we cannulate into femoral artery or vein because they're 18 years old or big patients, which kind of freaks me out a little bit. So some of the pros of this are, of course, you have visual identification of vessels, visualization of bleeding site. Some of the cons are increased risk of infection, time to cannulate, and yeah. So that's the biggest thing too. Is if you're going to go that route and you have a patient who's coding, of course, it takes longer to go on, and you have the risk of either losing the patient or just more issues. Central cannulation, I like these. It's my favorite ECMO to sit because you have usually better access and you have larger cannulas. So you have direct visualization of the aorta in the right atrium, of course. improve control of bleeding sometimes, and then cons is that you have an open chest. Sorry, it's not working well. Increased risk of infection and increased bleeding. But I find those we have better flow, laminar flow, smoother run. Just my preference actually, and improved drainage, and possibility of additional cannulas also. So if you need more support, you have a better opportunity, different vessels to cannulate to get better flow for your patient, obviously. And I cannot work this very good. So securement's a big thing, and we all want to be safe what we're doing, right? Because we have this patient's life in our hands. And so what we use mostly is this, and probably most of you use this, I'm not sure, is this cannula holder. We just make sure we have umbilical ties to the cannula, and when we do clamp it down to a bed, I always tell my staff, don't use the top sheet, use the bed. I don't care if you ruin the bed or not. Get down to the bed itself and make sure it's really secure. Here's kind of sort of what we do from internet, of course. I'm really impressed with all the talks I've heard, and over the years too, of centers that have patients up and mobile, walking around, and it's just really coming from an EOP center. It's crazy. I would love to do it, but people think I'm crazy for that. But just nice to see the types of head wraps and the types of securement devices that are out there. If anybody knows of anyone that has anything more of the neopeds size for the head wraps, please let me know, because I've tried to find something for our smaller kids and no one really has anything great. Maybe I shouldn't invent it, and maybe I could quit my day job, but it might be beneficial. So this is one of our patients, of course, is bleeding on the cannula site, but this is pretty much how we do it ours, and just with OptiSite and Mepilex under the cannula, which I'll talk about a little bit more later for infection control. And then safety, of course. So this is a real picture from our center. We had a 17-year-old COVID patient flown in from I believe Alabama, and it was like 4:30 on the Sunday morning. We got called in, and we handed the circuit to the surgeon, and it's from a cardio help. I don't know if you guys use cardio help. You have the quick connect, and he didn't grab it at the right spot. Went all over. So this patient had been coding for 45 minutes at this point. So it took a lot of, oh shit, what are we going to do, and put some volume back in the circuit and go on. It's pretty quickly, we got lucky. So I showed this picture just to my team when we do drills and stuff, just to really be safe, be sure what you're doing when you hand it off, make sure there's good communication, make sure you have the venous line or arterial line. So it was a pretty interesting morning. Didn't sleep very well. Patient management. So, ELSO has all their criteria, especially for neonates and peds, it's a little different, but we kind of follow the same thing as they do. We may have a couple factors that vary, but again, even for cardiac patients, we try to follow the same thing for our patient maintenance. It's interesting, we don't do any transplants at our center, but it's, I just reading about other centers who do this and how they walk their patients, really interesting. Sepsis, I remember when I first started, sepsis was a big no-no for ECMO, and in the last couple of years, in the last 5-10 years, has been more common to put patients on ECMO for sepsis. I've had a lot of fighting with physicians and trying to bring the current ELSO literature to the table and say the best science, like this is really, it's what we need to do. And in COVID, so being an EOP center, we didn't see a lot of, we saw maybe 4 or 5 COVID patients, had some success, some failure, unfortunately. But again, another use for ECMO obviously is COVID, and has really grown a lot in the past. Status post bone marrow transplant. Anybody have ever touched patients like this on ECMO? So this is something our HEMOC group has come to us numerous times, and they're pretty much end of life, so it's kind of too late, but it would have been a decent candidate had they reached out to us maybe 2 or 3 weeks before that. I just like to ask that question everywhere I go because I'm trying to build up more information on it.
So what's the issue with the status? I used to do bone marrow transplantation as a laboratory person.
Okay.
So what's the issue with it?
So usually the patient, when they call us, so normally our general surgery team who handles all of those types of respiratory and ECMOs don't feel like they're good candidates. And I think we need more education on the field for those guys.
When they get the transplant, they start having lung issues?
Yeah, more like ARDS. Yeah, going to ARDS. And like I said, but the problem is they call us a little bit too late. Like most people call us too late for a lot of cases too. So that's the thing, more of that. And trying to find more data for patients who go on a little bit sooner and try to help them out a little bit. And then we always have the issues of controlled bleeding and irreversible conditions that we have to go through. So early intervention, that is one of my biggest soapbox issues. One of them, at least, is how early do we go on, and timing is critical, as we know. So it's better to call us when we're getting a patient, because we don't have an L&D. Everything for us is transport brought in, so it's good to know ahead of time what we're getting and kind of be prepared. So I think timing is really critical for our patients and for all of them. So I think better management, better communication of what we expect to do with these patients is good. ECPR guidelines, we don't have an ECPR program per se. I was talking to Bridget about this earlier, and that, ELSA suggests that any patient that goes onto ECMO should be listed as ECPR. But, we don't have an in-house surgeon. We don't have in-house perfusionist. So administration really is kind of pushed back on that, but we're trying to kind of push forward with it. Then, of course, with good patient management and good communication, we all have our little miracles, like we saw our patient early this morning. So it's always nice to have that reward at the end of the day. So sedated or awake, again, I talked a little bit about this earlier, just really impressive. It really amazes me. It's really funny. I was telling our team in a meeting about, I saw an article, someone were riding a bicycle, and what I meant was stationary bike. And they're like, well, how do we keep up with them rolling a pump? I'm like, well, no, it's a stationary bike. Trust me. That'll be really impressive that we can make a TikTok out of that or something. And I felt stupid after, like, well, I should have said that. But I just think this is really, I would love to be able to do this, and we're not going to do this anytime soon, but I'm just really impressed with the centers that do this. So if you do it, congratulations. Really proud of you. And the safety about this, right? We're being safe when we travel. Obviously, they're very safe with this. Lots of people on hand, extra supplies with you, cannulas, so if anything goes wrong, volume. Then, decreasing anaerobic metabolism. I went to a lecture from a physician from Duke University, came to New Orleans, and he was talking about this with our transplant patients. And he said they trach them the same day to go on ECMO. Next day, they're up and walking. And I'm like, well, that's really, it decreases their lactates and everything. Just thought it was really amazing to hear how the ECMO, again, is different than other centers. Really impressive. I need to get that bicycle. That'd be really cool. So another thing we've talked about, you heard a couple lectures about is to ventilate or not to ventilate. So coming again, NEOPs, everybody's intubated. We do not take those chances, but it's nice to, we have a trach patient, and have this girl walking with a high flow cannula or RAM cannula, and then this patient who's obviously not going to walk. But it's just, I think it's really impressive. Of course, it's population specific, so yeah, those centers you're going to see that more, and then the communication and with with everyone else, and clearing the hallway with nursing, with everyone else. So it's just really, I still think it's going back to patient management. I think it just really makes a big difference. So some of the other management techniques: prone positioning. Anybody here prone patients on ECMO? Have done? Okay, successful, what I could read about. We don't. I'm still trying to bring that, after 20-something years of a program, still trying to convince some of the docs and surgeons to do this. I think it's really beneficial. OT and PT is something we introduced our program about 3 years ago. I just suggested, after all the reading, we've got to do something different. It's made a big difference. I don't know if you guys are using OT or PT in your patients, but I've seen some great benefits from it. Ambulation, again, we talked about. Not going to happen for me. Wound care, really different. So for a while, we were going through a lot of stages of skin breakdowns and really poor skin integrity. And, administration sees that. It costs money. And, I don't care about it costs money to save a life, but, they're worried about that too. So what we did is we introduced our wound care team to our ECMO patients on day one of cannulation. If it's, between 7 and 5 or whenever they work, they come to the bedside. We do a full patient assessment. If there's any pre-existing breakdown, and so we meet day one. Then every other day, so we make it Monday, Wednesday, Friday, basically. I go to the bedside with them. We have a whole team. We turn the patient. We lift them if they're small enough. Make sure there's nothing, anything could cause a breakdown. So we're really proud of ourselves. We went from a skin integrity breakdown rate of probably about 85% down to about 45% in a year. So of course the administration loves the money thing, but I think it's made a huge impact in patient recovery and in long-term infection or anything. So I think that's really made a big difference. End of life, we're talking about palliative care. I don't know if you guys, everyone have a palliative care crew in your hospital? Probably, okay. So we've only gotten a palliative care crew probably about 2-3 years ago. And so before then, we didn't have much support for the family. It was just all of us trying to be supportive of the family, being as real as possible without overstepping any boundaries. So we have them come by on day one of ECMO if possible. Again, kind of like the Monday, Wednesday thing, Friday thing. It's made a huge difference because for me, having the parents, having someone to talk to besides us, someone who's not as clinical to talk about their emotions, their feelings, has made a huge difference, along with pastoral care services. We do have a chaplain in-house about 12 hours a day. We have a couple of them that will be on call also. So they'll come by and, again, same thing, be supportive of the parents, supportive of us also. We've all go through our tragedies, I guess, right? We know the patient family for 2 or 3 weeks, and then it's hard to say goodbye at the end of that. So it's been great for all of us. And saying goodbye, of course, is rough, and for me, I think, being a parent is harder when you have a child who's probably at school age or older to deal with that, right? And it's not easy with any adults, I'm sure, but it's hard, and we have to go through that. And how do you manage that? How do you get your team to be on board to be better with that? And I don't think it's any way to be better. I think it's just a lot of support and for each other, and having support staff on the hospital side also. And home ECMO, everybody heard about this before? You did? Okay. So I used to make jokes about this, and that I'll create my own home ECMO program just to be away from the hospital, and everybody, it's silly, and never really being serious. And then so I listened to a webinar a while back, and someone was talking about how they had a patient with end of life, an adult patient. Patient wanted to go home as an adult one last time to see their garden or something. So they brought the patient, did a transport for the patient, went home for a couple of hours, and went back to the hospital, and they expired like a day or two later, I think. But I guess it's something newer. And if you heard that it was a long time ago, is it something recent, or I would love to hear about it?
I know a group in Sweden that does it.
Okay.
ECMO bus.
Yeah.
Patients that want to go home and sit on their board for the last time.
Right. Yeah.
They get them on the bus and take them there.
That's impressive. Yeah. So I think it's something we may see more in the future. Just kind of very interesting. Say what? So that's kind of sitting home ECMO. Say what? Say what? Yeah, it's fun to make fun of Bill. Yeah, so sorry, we messed that up a little bit. Huh? Yeah, exactly. Yeah. I won't tell him anything about that. Yeah. So talk about different types of pumps. We know there's not many, but quite a few different pumps out there. If you can do rollerhead or centrifugal. Bridget was just asking me, for the small kids, we use centrifugal. We do. We got rid of our rollerheads about 8 years ago, and all we use is centrifugal. Have not had any major issues, increased hemolysis or neuro insult. So we've been relatively lucky. And I just listed a couple of different pumps out there. I have only ever used a couple, and so I hear about these other pumps, and I've talked to Bill about this quite often, about, how do they work? He said, well, some of these, if you could work in 1980s VCR, you might be able to work this pump also. So it feels kind of fun. We have a very busy circuit, so looking at this might really freak some of you guys out. We, being in EOPs, again, I keep saying that, sorry. We infuse everything to our circuit, and I know there's a lot of beliefs out there, what works better, what doesn't work, and it's the same blood in theory, but each their own. We have probably 8 access sites that we actually use, and to make things better for our patients and our program, I've labeled each site with stickers, and I know it sounds kind of elementary, but there have been 0 instances of infusion at different wrong sites in about 3 years now, and because we had a lot of new staff come in, we've lost a lot of ECMO staff. So, it's at 3 in the morning where they don't want to wake me up to ask me is it right to put the heparin here or whatever. So it's made a big difference. Like I said, it's a very busy circuit, but it works well. And I think my soapbox to this is, right, I think we should never, if you go to another center to work, I think it's not always best to reinvent that wheel. And we've kind of dealt with that a couple of times in our last 20-something years. And I think what works for each center works for that center, and that's good. I think information or your advice from another center is great, but I think just reinventing a wheel in an institution that works well is damaging, I think, to a certain extent. So that's my soapbox for that. And I wish Soren had a smaller footprint, because it would be really nice to squeeze in. So again, for us, patient only. Some centers do patient only. We do circuit only. Some do both. And again, we have a very busy circuit. So again, here's a picture of we do use thrombate, obviously, but so one of the examples that we did to make things a little easier and safer for our patients. Circuit coating, I said a little bit a while ago. So, right, there's different centers, different vendors that have different coatings, and what coating is better. We switched to a different circuit about 3 years ago, and it has a Corteva coating. Not so sold on any coating, but at the same time, we did a major overhaul of our anticoagulation guideline. It was kind of loose for a long time. So we sat down for a couple of weeks, and nice and friendly arguments and conversations, and we came up with something that we thought would work well. And so I'm kind of proud to say, after going to this new circuit and the new anti-coag guideline, before COVID, we didn't change a circuit for about 2.5 years during a case. Before that, we had circuits changing constantly, oxygenators. So I'm not quite sold on the coating thing again, but that's another option to each center kind of looks at that and makes decisions of what works best for them. Of course, lab maintenance for your patients and your circuit maintenance, frequency, CBC chemistry and circuit cultures, of course. Heparin, so, we use heparin. We are starting to develop a bivalve protocol for patients who would go into HIT. We kind of looked at this mostly. We had a 17-year-old COVID patient on for about 25 days. Started circuit changes around day 14, and we did 4 circuit changes in 3 days, and then he took a really bad neuro hit, and so we came off and he expired, unfortunately. But we talked about bivalve, and I had a doctor say, well, we could get it in tomorrow. We're going to start using it tomorrow. So that's great, but we don't have a policy. So you're not using it until we get a policy on this. So we've built something as a backup plan. Have not used it yet, and we do have it on our formulary. Again, we use AT3 in all of our cases, no matter what. We keep it running. So again, ACT, 10A. The only thing I didn't put in here was TEG, because TEG is kind of new to us from like the last year, and it's still trying to get all physician buy-in for it. I know it's a great tool, and I think it really gives you a picture of what's happening. Like we had a presentation yesterday, really impressive. Anybody here use ACTs at all anymore? Us either. We were ACT driven for many years and realized it just wasn't best. We do run ACTs once or twice a day as a backup to, although 10A and AC doesn't have a great correlation, is in case our 10A machine in the lab often breaks, which is pretty sad. So we have to call back ACTs for a couple hours. PTTs and PT, we don't follow PTT a little bit, but we kind of got away from some of those. And then, of course, for your oxygenators, when is the time to change? We had a couple talks about this yesterday and today, in fact, in this session also a little bit. Historically, we've changed it when the grading got about like 60 or 70, which is still not really bad, but I think we forgot to look at what is the actual function of the oxygenator, right? Can we go for longer? Does it have great function? Can we go another day or so? Because if we change it, we know we have this inflammatory process. Do we want to go through that? So we've kind of improved some of those, and then what we do for our institution, and I know we've learned this from a few others, we just change the whole circuit now. We don't do just the oxygenator, just because there's probably some microclots in the circuit somewhere, so we just go completely everything. Anybody else follow that same practice? Or? Okay. All right. And then here's just a picture, we all know what clot oxygenators look like, but yeah, pretty nasty. So anybody here, is it only a perfusion prime program, or is only perfusion primes? Okay. So for many years, we only had 2 perfusionists on board, and we've come through a lot of situations where it's 2 in the afternoon, perfusionist A is home already, perfusion B is taking over the rest of the case, and we have a kid needs to go on ECMO. We have to wait 2 or 3 hours till they're off bypass to get someone to prime. So, probably about 2 years ago, again, I keep saying 2 years, 3 years ago, we had lots of changes. So decided that, we should be able to prime also, because as a respiratory therapist, I always tell the therapists, if you can't put a vent circuit together, you shouldn't be working it, right? So I thought we should be able to put an ECMO circuit together and do this since the perfusion is not available. So we did that, and it's worked out really well. We now have a primer in-house 24/7 because of the way we have our staffing set up. So it's something growing. Not everyone wants to do that. It seems scary, and it's a lot of responsibility, but I think it's made, I know for sure it's made response time a little better over the last year or two, so it's really good. Just have a picture of our 3 perfusions that we have now. Really great people, and they probably have made the most positive impact of our program in all 20-something years, so really proud of them. Here's one of our respiratory supervisors, actually priming a circuit, well, for wet drills, actually, it's not priming, but she was practicing wet drills, so we're just a picture of her, and she was one that's really, really bright, and I had to really, really pull some teeth to make her do it because she was scared, and now she is probably one of my best primers, so I'm really proud to say that we've kind of come a long way. In review, I do kind of talk fast in review, blah, blah, blah. We talk about a lot of things, and it's just trying to, it's really for me to understand what you guys are doing also to make our program better, because I think we could all get better no matter how long we've been doing this. Again, getting to try to talk to perfusions about what cannulas do and how they work it was kind of intimidating, but I took the challenge anyway. So this is a picture of me and my yacht that we're going to have a party on later today. Bill, that's mine, yeah, Bill paid for it actually, so PDC paid for everything. So we're going to have a party later today. Just meet me there. I should still be there. So thank you very much. Any questions?